I want to share with you something very sort of breaking news. So on this particular slide, I think you all recognize the iconic building. You recognize the city. This is London. Just about 10 days ago in London, there was a major Alzheimer's conference held with something like 2,000 or more new research presentations. So I just want to highlight for you the 3 or 4 top takeaways from this meeting so that you all are up to date. So the number one learning from London is that there was a report that suggested that 1/3 of all cases of dementia may potentially be preventable. And these are some of the top risk factors that they identified as being low-hanging targets for intervention. So first is that they found that early school education was very critical to building up cognitive reserve and reducing one's risk for Alzheimer's. Now, of course, that's not something that one can do if somebody's already in their 50s or 60s, but it's a strategy that one can do to prevent sort of the next generation of dementia risk. Smoking was found to be a risk. Hearing loss was found to be one of the biggest modifiable risk factors. And many of us sort of, take this for granted that, yeah, I have a little bit of hearing loss. A lot of us don't like to wear hearing aids. But there are studies that actually show that if you have hearing loss, then the parts of the brain that are related to memory shrink. And when the hearing loss is corrected, that shrinkage can be reversed. The other risk factors they found are obesity, high blood pressure, diabetes, depression, social isolation, and physical inactivity. So all of these things are fairly easy to intervene, and there is actually a very large clinical trial now planned in the United States called the Pointer Study, which is aiming to address all of these factors and to see if they can actually reduce a person's risk for dementia. So the other learnings that came out of London were things that you may already be familiar with. A number of studies showed that eating sort of a low saturated fat, complex carbohydrate diet with lots of fruits and vegetables, the so-called Mediterranean diet, is protective for the brain. Playing crossword puzzles may be protective for the brain, even though that study was not a definitive study. The other finding was that being multilingual, that is speaking more than one language, or playing a musical instrument. In some ways, playing a musical instrument is the same as speaking another language, may be protective for the brain. Good sleep may also be protective. And the last but not least, hospitals are bad for the brain. You go into the hospital for anything, whether it be pneumonia, an infection, a minor surgical procedure, the general finding is that you take a hit to the brain. And people don't exactly know why. And again, I'm painting all hospitals and all admissions with a very broad stroke, which is not necessarily true. But the reality is outpatient treatments are a lot more friendlier to the brain than getting into the hospital. So I want to now, so one of the things is even though all these amazing findings came out of London, not one of these studies actually focused in on are these findings equally good for men and women? Are they equally good for whites, blacks, Hispanics, Asians? No one has really gotten down to that level of detail, again, because the vast majority of these studies, again, assumed it's a one-size-fits-all. If crossword puzzles are good for one person, they're good for everybody. So I'm going to sort of now move to the next phase of my presentation where I'm going to talk a little bit about why there may be sex differences. And then in the last third of my presentation, I'll talk about how race and ethnicity may impact the biology of Alzheimer's. So this is a simple quiz, so you don't need to answer it, just something you can think mentally. What percent of Alzheimer's cases in the U.S. are in women? And then the second question is what percent of Alzheimer's caregivers are women? And I'll provide the answers for you a few slides down. So why is research on gender-specific medicine and gender-specific biology so important? Until about the early 1990s, virtually all big clinical research studies were done in men. And it was automatically assumed that findings from studies of males also applied to women. And this kind of came to a head in 1993 when there was a very large study done called the aspirin study, which was the classic study that showed that taking low-dose aspirin is good for your heart. It was done almost entirely in males. And people assumed the findings would apply to women. And at that point, I think it was a wake-up call where people said, hey, maybe this is not true. We need to include women in trials, and we need to make sure that we understand whether the treatments that work in men also work in women or not. And the reason for that is we know from other literature, for example, there are obvious differences between men and women. I think everybody knows that. But we also have known for a long time, for example, that drugs, the dosing of drugs often needs to be changed between men and women. Women may be more susceptible to certain side effects of drugs, et cetera, et cetera. And of course, at a more fundamental level, I think we all understand that there are genetic differences between men and women, and I'll get into that. So after that law was passed, which is the law that the NIH passed in 1993 called the NIH Revitalization Act, which mandated that women be included in clinical research, scientists started discovering all kinds of very interesting sex differences. For example, they found out that men were much more likely to get strokes. They were much more likely to get heart disease and vascular disease at a younger age. They were much more likely to get lung cancer, and they were much more likely to get hearing loss. And they also found that women were much more likely to get depression, much more likely to get certain autoimmune disorders such as type 1 diabetes, which occurs at a young age, and multiple sclerosis, a brain disease, as well as osteoporosis. So it's very clear that diseases don't affect men and women the same way. Now, when you look at the genetics, now this is obvious. If you ask the general population which chromosome is bigger, the X chromosome or Y chromosome, I think a lot of people will say, the Y chromosome, because they'll say, okay, Y is associated with men. Men are usually taller, bigger, so it's probably a bigger chromosome. But surprisingly, the X chromosome shown here in pink is almost 5 times bigger than the Y chromosome. So for those of you who don't know the X and Y chromosomes, these are sex chromosomes. Women usually have 2 X chromosomes, and men usually have a Y and an X. Okay, and in terms of genetic differences, the X chromosome has something like 1,000 genes, at least what we know today, and the Y chromosome only has a puny 50 or 60 genes. So the X chromosome has, almost 20 times more genes. Could some of these genes impact the biology of Alzheimer's? It's very plausible. There are massive changes also that occur hormonally during menopause. There are so many different types of sex hormones that are different between men and women. So it's very, very plausible that all of these can lead to different biochemical pathways to getting Alzheimer's in men versus women. So when we sort of fast forward, or at least move from a sort of the broad study of gender medicine to Alzheimer's, I think many of you will remember that the very first case of Alzheimer's that was described by Dr. Alzheimer back in 1904 was a woman. And if we fast forward today, something like 110 years, what we're seeing today, at least in the U.S., is that 2/3 of people with Alzheimer's are women. And roughly 2/3 of caregivers are also women. So women are bearing the brunt of the Alzheimer's epidemic, at least in the U.S. The ratios are slightly different in some other countries, but in the U.S., there's reasonable evidence that 2/3 of people are women, even though the actual numbers have varied slightly from one study to another. Now, we don't know the reason why, so that's the billion-dollar question. Now, people have always known this statistic that there's sort of a higher prevalence of Alzheimer's in women, but people have assumed that this is an artifact of the fact that women tend to live longer than men. So this graph on the right side shows the life expectancy of someone if they are currently at age 65, and you can see the average life expectancy of a woman is about 21 years or so on top of the 65, whereas the average life expectancy of a man is something like 19 years. So yeah, naturally, if women live longer in any sort of pool of Alzheimer's patients, you would expect to see more women with Alzheimer's than men. So the thinking was that it's not truly a biological difference, it's just an artifact of the fact that women live longer. But more recently, studies have suggested that that may not be the sole explanation, that there may be a number of other biological factors also at play. So one of the studies that sort of raised this possibility was a study from Dr. Seshadri et al. In 1997 that showed that at each specific decade of life, the risk of Alzheimer's was probably higher in women than in men. So on this graph, what you're seeing is on the vertical axis, you're seeing the risk for developing. So if you see at age 65, the dark brown bars are for men, the light brown bars are for women. You can see at age 65, the risk for a man getting Alzheimer's is around 7 or 8%. And the risk for a woman getting Alzheimer's is a little over 15%. So it's almost double. And you can see similar differences in the 7th decade of life and also in the 8th decade of life. Now, this suggests that it's not just an artifact of women living longer. There is something biologically going on that puts women at greater risk for Alzheimer's. Now, if we were to turn to the laboratory and say, okay, is there any sort of insights or clues that we may get from laboratory mouse model studies? The sad answer is unfortunately not. And the reason for that appears to be something that's very surprising. It even surprised me. It turns out that virtually all of the mouse studies done to look at Alzheimer's mechanisms are done in male mice. There are very few studies that are done in female mice. And again, I think the thinking there is that maybe female mice there are a lot of hormonal and other issues that may complicate the interpretation of the data. So for some reason or the other, it's become a habit in the scientific field to only study male mice. And so the laboratory data doesn't shed much light. So if you sort of summarize all of the literature that we know so far as to what is the biological, potential biological mechanism by which women may be at greater risk? The short answer is we know very little. There are some findings that have come out in the literature. One of the findings is something I suggested earlier, which is that women may have a greater vulnerability to immune diseases. And one of the thinkings is that Alzheimer's may involve some alterations in the immune system in the brain. So it's possible that maybe women are more vulnerable for that reason. There's also some evidence suggesting that women may be more vulnerable to the effects of Alzheimer's pathology, such as the amyloid plaques and tangles. Now, but there is also some contradictory evidence. We know that men are much more likely to get vascular disease. They're much more likely to get silent strokes in the brain. They're much more likely to get blockages in the brain, much more likely to get heart disease at a younger age. So that would put them at greater risk for developing cognitive impairment. And there's also studies that suggest that the verbal memory of men as they get older declines at a faster rate than men. So again, there's contradictory evidence. Now, if you turn to the genetics, there have been a number of very large genetic studies, the so-called GWAS studies and others. Most of them have not examined for sex differences with regards to Alzheimer's risk. That, again, is very surprising, given what I told you is the obvious, differences between the X and Y chromosomes. So the short answer is, I like this quote from Socrates. He said, I know that I know nothing. So that's kind of close to where we are with regards to sex differences in the biological risk for Alzheimer's disease. So I'm going to turn to the next topic which I mentioned, which was what do we know about how race and ethnicity affect the risk for Alzheimer's and the biology of Alzheimer's. Again, as you can see from this slide here, America is truly a melting pot. And as I'm going to show you some statistics, it's going to become increasingly a melting pot, more so than what it is today over the next 20, 30 years. So this is, again, a mini quiz for you just to think about to see how much your actual knowledge is. So the first question is, what percentage of elderly are minorities? So minorities could include, any of the underrepresented races. And then how will this percentage change in the next 20 to 30 years? So let's look at the data. So currently, minorities are the fastest growing segment of the older adult population, 65 and older, in the U.S. And this slide is showing the projected increases in minority populations between 1990 all the way through 2030. You can see that within the next 15 years or so, the white population is expected to grow by 93%, whereas the non-white population is expected to go by 328%. Okay? Hispanics are projected to grow by 555%, African Americans by 160%, Asian and Pacific Islanders by 300%. So currently, minorities are probably, the entire pool of minorities in the U.S. is somewhere around 30% or so. The percent of minority elderly is around 30-35%. Over the next 20 to 25 years, this is going to exceed 50%. It's probably going to approach about 55%. So whites are going to become a minority. White elderly are going to become a minority by definition. And the accumulation of all the minority races put together are going to exceed 50%. So again, it's going to become very, very critical to study that population and see if there are differences amongst different racial and ethnic groups. Now, the terms ethnicity and race do not mean the same thing, even though sometimes they are used interchangeably. Race typically refers to a genetic trait. So the original definition, there were just three races. There was the white Caucasian race, there was the African American or the black race, and then there was the Asian race. And ethnicity, of course, people identify ethnicity based on cultural and national origin. So you could be Korean American, you could be Japanese American, you could be Indian American, Italian American, so on and so forth. So ethnicity is not the same as race. Ethnicity is very culture dependent. So let's look at some data. Again, there is a paucity of data looking at how race affects the risk for dementia. So one of the studies that's very well done is called the Health and Retirement Study. This is just a study of a random cross-section of older Americans. And this study found that amongst the proportion of older Americans with cognitive impairment, there was a higher proportion of African Americans who had cognitive impairment at every age group. So African Americans in this graph are shown in the orange bar, white Americans are shown in the dark brown bar, and Hispanics are shown in the gray bar. And you can see in every age group, white Americans have the lowest proportion with cognitive impairment, whereas African Americans and Hispanics tend to have much higher rates, sometimes twice or thrice the amount that whites have. For example, if you look at age 75 to 84, only roughly about 10% of whites have cognitive impairment compared to something like 30% of African Americans who may have cognitive impairment. Again, suggesting that something is going on there. So the next study was a study that looked specifically at the risk of Alzheimer's disease in different ethnic groups. So what you're seeing are a bunch of different graphs, and what you're seeing on the vertical axis here is something called as cumulative incidence. That is the new cases of Alzheimer's that are developing over time as each person's age increases. So what you're seeing, the top arrow is African Americans. The middle arrow is Hispanics, and the bottom arrow is whites. And so what this graph is showing, again, is that whites appear to have a much lower incidence for Alzheimer's disease than Hispanics, and Hispanics, again, appear to have a lower risk for African Americans. The second thing they found in this, which is very interesting, is that the most common genetic risk factor for Alzheimer's is a gene called the ApoE4 gene. And this gene, if you have it, you inherit it from your father or your mother. And if you have one copy, it increases your risk about 2 to 3-fold. And if you have inherited one copy from both your dad and your mom, then it increases your risk even higher, maybe 6, 7, 8-fold. And they found in whites, the gene clearly has an effect. People with that gene have a much greater risk for developing Alzheimer's. People without the gene don't have as high a risk. But amongst African Americans, they found that having this gene didn't seem to make a big difference. And that suggested that there may be other hidden genes that are yet to be discovered that may be raising the risk for Alzheimer's in African Americans, or there may be other mechanisms that we are not aware of. And one of the mechanisms that's been proposed, and again, this was a finding that just came out a few days ago, suggesting that African Americans who live in this region, marked in orange in the map of America, this region is called the stroke belt. African Americans who live in this region tend to have the highest risk for dementia. And they carry this risk with them, even if they move out of this region to other regions. So, for example, if you were born in one of these states and you moved out, and then you were living in California, then you carry this risk with you, and you still remain at higher risk for developing Alzheimer's. Why is that? We don't know. The stroke belt is one of the poorest regions. It's one of the regions with relatively low literacy rates. It's also a region with high rates of obesity, high rates of hypertension, high rates of diabetes, and it's obviously called the stroke belt because people here have high rates of strokes. And their dietary patterns may also be different. So we don't know if there's a genetic component to it, or whether it's entirely a lifestyle component, or whether it's both. But clearly, there are interactions between where you live in the United States, your race, and your risk for Alzheimer's disease. The last study I want to show you is something very interesting. So researchers said, okay, if African Americans living in the U.S. are at increased risk for Alzheimer's disease, does that also apply to Africans living in Africa? And that kind of a cross-cultural study is very important because it can give you cues as to whether it's purely a genetic risk or whether it's a lifestyle risk. Does moving to America to a particular region and adopting a certain cultural lifestyle, diet, or whatever, is that what conveys the risk, or is it purely a genetic risk of being belonging to a particular race? So what they found was that African Americans living in a particular region, not Africans living in a particular region in Nigeria called Ibadan. This particular city is Ibadan, shown here. You can see it's a bustling metropolis. It's obviously less affluent than the United States. But what they found was that Africans living in Nigeria had a much lower risk for Alzheimer's disease than Africans living in the United States. Again, that would suggest that maybe it's not a pure genetic risk. Maybe there is a significant portion of the Alzheimer's risk that is lifestyle related. So again, that could be good news because if we can identify and pin down what that lifestyle is, then we can modify it. And the last thing I want to bear in mind before you automatically assume that, that African Americans have much greater rates of cognitive impairment is that our screening tools for dementia may not perform the same way across different races, because some of these tests may suffer from racial and cultural biases. They may require a certain level of education in order to perform accurately. And a number of studies have suggested that there may be higher false positive rates in African Americans. So again, this is such a fundamental issue. If we don't have the right tools that are culturally and racially accurate, then how can we truly ascertain what is the true rates of dementia in different groups and different communities? So the bottom line, I think what I've been trying to say is there's a paucity of data, and there has also been relatively little progress. Both of these are urgent needs for our field. So there are two real hypotheses right now that, are the leading hypotheses. One is called the amyloid hypothesis, which suggests that amyloid plaques in the brain or amyloid proteins that are misfolded trigger the disease. The second hypothesis suggests that there may be a vascular pathway. Hypertension, high cholesterol, bad lifestyle, small strokes lead to Alzheimer's disease. Could it be that perhaps men are going down one pathway and women are going down the other? Could it be that people of a certain race are going down one pathway and people of another race are going down another pathway? We don't know. And that's the kind of thing that I think we should study. So in summary, I think what I've tried to emphasize and highlight today is that sex, race, and ethnicity appear to have a strong influence on the risk for Alzheimer's. But really, in our field, our diagnostic criteria, the biomarker timelines, the drug discovery processes don't really take this fully into account. It should be a high priority for further research because, one, it can offer new insights into treatable and reversible mechanisms. And ultimately, the goal is to personalize treatment. That's the goal of precision medicine and personalized medicine. And this kind of gender medicine and study of cultural and racial and ethnic effects may really help us better personalize our prevention strategies. And it's also the right thing to do. So I really want to thank you, and I think as acknowledged in the introduction, I've received grants and served as an advisor to a number of agencies and businesses and nonprofit organizations, and I want to thank the Cure Alzheimer's Fund and really all of you for your support. The Cure Alzheimer's Fund has given me a grant to begin the study of how sex differences may affect the risk for Alzheimer's. So I want to stop now, and I'd be delighted to answer any questions and take your comments.
Of the project that you'd already been working on with us, and I know you haven't concluded it yet, what's your sense of the question about whether women with mild cognitive impairment progress to Alzheimer's at faster rates than men?
Yes, so thank you for that question. So the project that we have been funded by the Cure Alzheimer's Fund is to analyze a very large database of a national study called the Alzheimer's Disease Neuroimaging Initiative. It's a study of about 1,500 people that have been followed for up to 10 years with a number of tests, biomarkers, brain scans, etc. And this is a great database to really look for sex effects because roughly about half the people are men and half the people are women. Now, before I get to the sex findings, we also took a peek to see if we could find any race effects. And unfortunately, the number of African Americans enrolled in the study were so small that we did not have enough numbers to test whether there were any effects by race. Now, what we did find was amongst people who already had been diagnosed with mild cognitive impairment, women tended to decline at a faster rate than men. Now, I don't want anybody there on the phone to think this is the last word or that it's definitive. We're still trying to confirm these findings. But for those of you men on the line who are thinking, oh, this is good news for us, there are some data coming out suggesting that at an earlier stage, that is, if you have normal cognition, then men tend to progress faster to the stage of mild cognitive impairment than women. So there may be differences in risk by sex at different stages of Alzheimer's disease. So this has to be ascertained more fully.
Right. Well, that's a great question that you've asked, and we're pleased to try to help with it. With regard to the differences in the sexes, a common question that we often get is the role of menopause and estrogen in Alzheimer's. How does that contribute to the differentials?
So, great question. It's been studied. That's one of the few areas that has been studied. It's very clearly known that during menopause, there are cognitive changes in a subset of women. And it's also, there have been two large trials looking at whether or not estrogen and combination estrogen can help women lower their risk for dementia. And the results of those two trials suggest that progesterone and estrogen do not reduce your risk for dementia if you're a postmenopausal woman, and in some instances, they may actually increase your risk for dementia. So this was sort of a counterintuitive finding. So the short answer is we still don't know the best way to manage memory changes and tip of the tongue kind of changes that occur in women following menopause. There may be other chemical changes. There may be other ways of delivering hormone therapy, such as natural hormones or mimicking the body's own rhythms that may be better ways of treating women. So those kinds of things still need to be researched.
Right. Okay. And that takes us back to, and there's another question here from someone, which is excellent, that you mentioned issues with data and databases that we have at our disposal. My understanding is that a large amount of research is done from databases that we've had for a while, genes that have been studied in DNA submitted for a while. What are the challenges in dealing with those existing databases and trying to understand these differences? How do we update those databases?
Great question. The first biggest problem is most of these databases exist in silos. People seem to be very protective of their data, even if it's been funded with government money or money from nonprofit organizations, where the intent is to have the data be widely shared. So we have hundreds of individual databases, each of which has small numbers of subjects. And if there's some way that we could combine all of them, it would be a very powerful tool. The second thing is the diagnostic criteria for Alzheimer's disease changed twice over the last 4 decades. Once it changed in 1987 or so. So a lot of the data collected before 1987, the criteria was made using older criteria, so it's hard to sort of compare that to today's criteria. And then about 3 years ago, again, we revised our criteria where we started diagnosing Alzheimer's using biomarkers based on pathological and spinal fluid and brain scan data. So that's the second issue. So I think clearly what we need to study gender effects or race effects is to prospectively design a study that's intended to look at that.
Yeah.
And that's really the best way, especially we looked at about 20 or 30 databases of clinical trials, and we found that most clinical trial databases have such low numbers of African Americans that you can't really reasonably study them. So you really need to create and design a study that enrolls sufficient numbers of individuals across different ethnic groups in order to be able to come to conclusions.
And I know that there are a number of organizations trying to develop registries and groups of people available for these studies. So one of the things that all the rest of us who are not researchers can do is be ready to volunteer for those registries and those pools. Is that right?
Sure.
Yeah. Okay. Another question, and let me just read this question that was submitted. Are there sex-specific changes in daily function or brain areas that are hit first?
Well, we don't know the answer to that. I think there may be. And clearly, you know, men tend to do different things and women tend to do different things, especially the men and women of the generation that are getting Alzheimer's today. So the short answer is we don't know, and that's one of the things that needs to be studied.
Okay.
So we are looking at brain changes in the study that Cure Alzheimer's Fund has given us, and we are planning to systematically look to see if there's differences in the types of brain regions that are affected in men versus women.
Okay, great. Just a couple more questions, Murali. Thank you very much for your time here. Can you speak more to the hearing loss and Alzheimer's? I have a number of people who are quite interested in that.
I think it's the single biggest risk factor that we do a very poor job of addressing today. a lot of people have mild levels of hearing loss, and we think, okay, we're just going to live with it. And I think what we are not realizing is that the brain relies on information coming from our senses, whether it be our eyesight, our hearing, our smell, our touch, in order for our memory centers to be alive and well. When it stops receiving information from our hearing, then the parts of the brain that store memory tend to shrink. And so it's a two-way communication between the brain and our sensory systems. So people with moderate to severe degrees of hearing loss, there was a recent study that showed that a number of people with moderate to severe degrees of hearing loss underwent what's called as a cochlear implant surgery. So this is where they implanted a small device into their inner ear to help them hear better. And something like 30% of patients who had previously been thought to have Alzheimer's, they were now declared to be normal after this cochlear implant surgery. So their entire so-called Alzheimer's was really a false diagnosis caused by cognitive impairment due to a severe hearing loss.
Wow.
So we don't know today, out of if we say there are 5.5 million Alzheimer's cases in the U.S., my guess is that 10 to 15% of those cases or more probably have reversible cognitive changes induced by hearing loss.
And we certainly know that Alzheimer's or no, the loss of hearing narrows one's world tremendously.
Oh, completely. Completely. Even if you do have true hearing loss, then true Alzheimer's, then the hearing loss is an added disability on top of that.
Yeah.
And it might well make your true Alzheimer's progress at a faster rate.
Yeah.
Because many of the brain regions involved in hearing are also some of the regions that are affected earliest by Alzheimer's.
Right. Okay.
And the same is true for smell as well.
Right. And is there any study showing, crudely put, which of those is the first to go?
No. The short answer is no. I think both go, early. We're just more aware of our hearing loss. Most of us are blissfully aware of our loss of smell. But the interesting thing that I mentioned is that women are less likely to get hearing loss than men. And I think that's a great area to study. Yeah,
interesting. Okay, last question takes us back to the differential between the amyloid hypothesis and the vascular hypothesis, pathways, I should say. In your view, are those entirely different pathways or differences in emphasis and physiology, essentially?
Great question, and I tried to show them as two separate pathways for simplicity. The reality is everything in the body is interconnected. I think so these should not be taken as two completely parallel independent pathways. They talk to each other. And the reason I say that is, for example, amyloid plaques can form inside blood vessels, and they can block blood vessels.
Yeah.
So each pathology may affect each other. Small strokes can then possibly may trigger, inflammation, which can then trigger amyloid formation. So we don't know how these pathways interact with each other. I think the point I was trying to make is that if men develop vascular disease early in life, then that might be the initial triggering event for them, and it might be a different triggering event for women.
Right. Okay. Murali, thank you very, very much. We really appreciate your expertise and your time on this and sharing it. Very, very helpful. Thank you. And,
my pleasure.
So thank you all very much, and we'll look forward to joining you the next time we do this. Thanks, and goodbye.